outcomes and the health of communities. Welcome, Dr. Bhatt.
Thank you.
Thank you. We are also privileged to have Christina Floyd with us today. Christina is the health director at the Fort Mojave Indian Health Center in Arizona. Prior to this role, Christina was the director of the Gila River Indian Community Health Department. Her expertise and leadership skills have been extremely important during this COVID crisis. Welcome to you both. Thank you.
Thank you.
So I think we're starting off with Jay Bhatt, please, with some few remarks, and then Cyrena will ask some questions.
Sounds good. Thanks so much for having me. I'm really excited about the work of the coalition and focused on these really critical issues. And the COVID-19 pandemic has certainly further illuminated for us the importance of equitable, high quality, affordable care. And so wanted to share a bit about some of the work that I'm involved with in Chicago, and raise some points of discussion that we'll get to certainly in the questions. But one of the areas that we're seeing opportunity is that from a health system perspective, data liquidity, data wrangling, predictive analytics, and integration of data across different sectors and domains has been critically important to help us understand where there's systemic gaps and inequities that impact health. And so we're hearing a lot lately about the social vulnerability index. There's the hardship index. And a lot of these are developed from public data, and then there are proprietary models that are developed based on data that comes from various organizations in their approach. So we've developed, with my current role at the Medical Home Network as Chief Clinical Product Officer, a model for transforming the safety net. And so it reflects a unique proven model in Chicago that transforms systems of care and consistently delivers leading Medicaid health outcomes and quality results under value-based arrangements. So we go and take a disconnected, inefficient safety net where stakeholders act independently into a digitally connected and clinically integrated safety net network that works to reduce systemic care gaps, social determinants, and health inequities. Now, it includes community health centers across Cook County in Chicago, 3 hospital systems, delegation for care management, which means we work with our provider partners for care management, and we're at risk for total cost of care. So we're really hyper-focused on doing things that are evidence-based, that are appropriate, and what this allows us to do is drive cultural transformation and advance integrated practice level model of care. And what's so important to being able to do that is our platform, MHN Connect, which brings together health risk assessments and data from that. So we do a health risk assessment on every patient that we have to understand what their current state is, the communities they come from, what those communities' challenges are, what their social, family, cognitive, physical capacity, and functional status is. And so 355,000 of them now allows us to understand patterns and look at data in an integrated way to try to identify where we should intervene, where we should focus our care management and care coordination, risk stratify based on social determinants of health, medical, behavioral conditions. And then the platform supports dynamic daily AI risk stratification. And so we've worked as to take this self-reported health risk assessment, our clinical data, and public data to feed the model and then learn over time. And the result is that we've identified nearly 40% of a reduction in total social risk factors impacting health. And so that allows us to deliver the right care at the right place at the right time and actually get out in front. So this notion of, can I have next week's dashboard today, is where we want to get to, and where we're hearing health systems and provider organizations want us to get to. And for COVID, we leveraged again the MHN Connect, which is a 360 member view care management platform to try to identify high risk COVID patients to frontline care managers who then drive proactive outreach and interaction and follow up. And so just this past year, because we take risk over the total cost of care, and it's really enabled by the platform and the data integration and data that we connect to insights and then feed that to our stakeholder partners to take action. That's allowed us to have 30 million in shared savings in this past year for our members in our accountable care organization for Medicaid. And then we just started a Medicare Advantage health plan called More Care, which brings the continuum of Medicaid, the duals, which are Medicaid and Medicare, and then a component of Medicare Advantage. And we're focused on chronic populations, populations that live in long-term care, nursing homes, senior living, assisted living, as well as looking at how do we have a model of care, but then the data elements, that support it. But it's a really interesting area called the SNPs, the special needs plans within Medicare Advantage. And there's a huge potential there. Now, the life sciences is another important area where we're seeing a lot of different applications of data and organizations that are trying to become particular data brokers and to support data needs from care action to clinical trials to identifying gaps and opportunities for intervention. So, I think that there's huge opportunity for the future of data, but some of you may have seen the recent announcement by 14 health systems to come together to share data, because that's how you can get scale and to try to disrupt some of the other players out there. And so that they're going to share data so that they can drive insights, reduce variation, and identify innovation. So that's an interesting, approach, and we'll probably see that happen in other sectors as well. And more folks will come on to this, initial 14, but it could become much larger over time. But I think that the other big issue I talk about is data disaggregation. I also think that you can't improve what you don't measure or you don't see. And so I think we've got a lot of work to do, particularly on racial and ethnic minorities and other populations, those that are disabled, those that have special challenges. We need window and insight into that data that not is always available. So I want to stop there and turn it back over to Serena.
Hello, so I'm Sarina Garuga. I am the Director of Operations here at PTech, and I want to thank Jay for that really lovely introduction to what we'll be discussing today. I don't know if Christina, you wanted to say a few words about yourself and what you do at the center before we get started. Oh, I think you're
Hi,
on
good
mute.
morning, everyone. I was on mute. My name is Christina Floyd. I'm the Mojave Indian Health Center Director. I've been here since July 2019 in this capacity. Prior to going into healthcare, I've been in public health for well over about 15 years or so. Before this particular, I've been the Tribal Health Department Director for the Gila River Indian community down in south of Phoenix, Arizona. So I've had the best of both worlds with regards to public health as well as healthcare. And in this capacity with COVID, it has been, I would say, a daunting experience for this small tribal community. There's only roughly about 1,400 enrolled members within the tribe that we work for, and a very small community in what's called Mojave Valley, Arizona. So it's even rural Arizona. However, we've really been able to maintain throughout this time. And Dr. Bhatt talked about data, and within Indian country, that is still a huge critical issue regarding data sovereignty, data quality. We know that unfortunately our American Indian population, especially in our larger facilities, such as either in the Phoenix area or any other metropolitan area, they're often not captured accurately with regards to demographics. So when we talk about data in Indian country, there's a lot of miscommunication as well as misinformation. And so with that, a lot of the tribal communities have been doing their due diligence to try to be more cognizant of data sovereignty, what that looks like with regards to how their community owns the information that they capture, but also how it's presented in a manner that sheds effective light and not so much negative light, but effective light on the communities, the American Indian Alaska Native communities. We also see within COVID, just like with any other underserved populations, the disparities of inadequate testing with regards to COVID testing, but also the inability to message appropriately to communities to convey the importance of either testing or now with the vaccine. So being able to have information that is shared across Native American communities that will allow for their trust to become more visible within the healthcare system that has so often plagued them has been a huge, I would say, ordeal. We've been fortunate that because our such small tribal community hinges on the communities around them, we've been fortunate to have a higher vaccination rate than some, simply because a lot of the tribal community members are also employees of the tribe. So they saw the importance of being able to have a robust vaccinated employee system to be able to continue to provide services to their own population. So which is really the role of what's called self-governance. And so I've been fortunate because the Fort Mojave Indian Health Center is self-governed, which means the tribe runs the operations versus Indian Health Services. And so it's called IHS 638. With that being said, a lot of the communities have been hit hard. You do hear data trends, unfortunately, of 1 in every 475 Native Americans have died from COVID this past year. We have had the fortunate opportunity of not losing nearly as many lives as what other tribal communities across the country have. And I think we really attribute that to upfront leadership. We have great chairman as well as vice chairman and council members who spearheaded the effort of making sure that the tribal communities were aware of the importance of emergency preparedness, being able to properly implement any of the numerous prevention methods that we have within the community. And so while we had our growth spurts of some small outbreaks within the community, our death rate has been very, very, very low. And even to the point of our active cases, we've been able to get those down substantially. So we really look forward to be able to moving into the next phase of really reopening the community back up next month or so, and seeing how the activities of emergency preparedness, but also public health and healthcare have been able to integrate to fight the COVID battle within the community.
All right, thank you for that. So in opening, I think I'd like to ask both of you sort of a very straightforward question. So I would think in many of these communities, racial and ethnic minority communities with the disabled community, the idea of collecting data can be very sensitive and fraught with, I suppose you could even say, intergenerational trauma of how people have been abused by the healthcare system and public health. So how do you approach the, I guess, the idea of collecting sensitive data points about people, about their income, about their housing status, things like that? How do you approach that with their populations and sort of sell it as a positive thing for improving the quality of their healthcare?
You know, so I can start. I would say one, we have to acknowledge and validate that there are real concerns about how data has historically been handled, how it's been used, and recognize that that is something that's happened, and then pivot to saying that it's really important for us to have the data in order to help improve your health, and in order to understand the health of the community, in order to give you and the community better opportunities. And I often share examples of how having information has made a difference for some of my patients at the individual level, to other, patients in a broader sense. But often, being able to show the impact and change. I think if patients and families, and people think that and really believe in the data being used for good, for being used for improvement, for being used to get towards equity, I think, and they really believe that, I think they're in a better situation to be a partner in that effort. And so I also think illuminating, the gaps that we have. We can't, just recently on the COVID piece, we've seen gaps in understanding even which racial and ethnic minorities or special populations have gotten vaccinated and in what communities. Some of that data is not clear. And even in the Asian American community, we've seen disaggregation be an issue. But I think that's where I start. And hopefully that small acts of support and transparency builds trust over time. And you can do more. And now the other thing I would say is that there is public data. I think reminding people that they're already sharing data in their day-to-day life, and also educating them about that. But then at least an awareness that, that data is available, and we would all want to use it to improve health.
Okay, Christina?
I kind of alluded to it in my previous statement. However, building the capacity of tribal communities to understand their sovereignty regarding data, and understanding that they do own the rights to their information, and allowing them to understand how that can be used to, as Dr. Bhatt said, to move forward and to go so far as the individual level of how you can help others. We looked at intergenerational trauma, especially with Native Americans and Alaska Native, with regards to how the information over time has been used, unfortunately, to either discredit or disregard many of the health equities that have, or inequities rather, that have been seen within our communities. The biggest hurdle that we've seen that allowed us to overcome it was to focus on the tribal elders, look at those who are within the communities, who are our allies, provide them, as I said, with transparent information, having them understand the critical pieces of the information that we use, and also, again, letting them understand that at the end of the day, the information is really used for the ability to be able to help the community more. In doing so and having those critical key allies with regards to your elder population, those who are the language speaking tribal members within the community, those individuals really push forward either campaigns or information to get to the community, because those are the ones who we're seen as the trusted individuals within the community. Even though you may have your experts and you may have your information, if they have a trusted face and they have trusted information coming from individuals that are working in tandem with you, they're more likely to really, as they say, get on board. And so being able to use that information was really critical. We've even seen just so recently with, it was unfortunately one big institute here within Arizona that had used information, not just information, but research information. So making them, as Dr. Bhatt said, having them understand it's legitimate concern, not negating anything that they bring to the table, but also utilizing information when asking them about how can we improve, and really letting them see that you're using the information that they give you. I think that too is another critical piece with having them see their input being implemented in their healthcare system, to let them know that they're being listened to, and that they're also being understood. And I think that's a really critical piece when working with Native populations.
Thank you for that. So Dr. Bhatt, oh, sorry. So Dr. Bhatt, you've written fairly extensively about, value-based care models. But there are some experts who think that there is the possibility for unintentional exacerbation of health inequity when using these models. So, you've talked a little bit more, you talked a little bit in your introduction about accountable care organizations and Medicare Advantage. How do you think that programs like that could be used to advance health equity in vulnerable populations?
Thank you for that question. And one, I just want to also um, appreciate this work and the team and the invite from Kirsten and Benson. And I think I'll start with this some numbers. In the model that we're driving, and there's Medicaid accountable care organization um, efforts happening around the country. But if we're saying that we want to get to health, a fee for service system uh, isn't necessarily going to get us there, particularly with vulnerable populations. So in my own clinic, I have 15 to 20-minute visits.
Mhm.
And if we don't reorient that into saying, well, what's the right amount of time or space needed with someone who in vulnerable communities, then I think we do that population a disservice. And it's important to have uh, the space and time to think appropriately and do the things that matter. And so, we've seen a 36% reduction in inpatient hospital days. So keeping people healthier, at home. 27% reduction in hospital admissions, 12% reduction in readmissions, 11% reduction in ER visits. Um, for nearly 50% post-ER follow-up within 7 days, which is really important, to have continuity care and support follow-up that's needed, and an increase in primary care visits by 15%. So you're seeing, and nearly 90% of the patients complete the health risk assessment. So, there is a not only a quality case to be made, it's not only the right thing to do, but there's also a business case that I alluded to earlier from a shared savings model. So those shared savings can then be reinvested in doing what is right for the patient, the family, and the community. So you can deploy it around air conditioning needs that might impact respiratory conditions. You can deploy it around affordable supportive housing. We know that unstable housing reduces life expectancy on average by 27 years. Housing is health. We can use it to drive transportation support. We can use it for food prescriptions to address food insecurity. You have different ways to use the resources to better support the patient as a whole. And so I think that's really the idea. It's about doing the right thing, not doing as much of it, because then you're just focused on getting through the volume and you're not necessarily always driving towards the needs of the patient. And I would say, that some examples to think about is um, there are situations where we've seen some evidence around value-based systems unintentionally exacerbate inequity. And so think about when there's knee replacements. We've seen African American Black communities be negatively impacted because they're not necessarily going home after that knee replacement. They may be going to a facility for post-acute rehab because or other support because they don't have support at home. So part of this is patients who receive high-touch personalized care are less likely to delay essential care, which we know vulnerable populations may do, and less likely to go to the emergency department for non-urgent care, which then impacts kind of their also avoidable costs and visits. So, I think when I think about who vulnerable populations are, those with 4 or more high-risk chronic conditions, those that live in particular communities that have a lack of access to primary care, poor economy, high unemployment rates, high rates of people who are uninsured, underinsured, social, cultural, language barriers, low education levels, environmental challenges like unsafe streets or few places to exercise. Now those, are challenging, and so you need a different model of care and partners to drive that forward. And so I think value-based care is the way forward, and I think we got to do, more of it so that we're organizing care around what the right thing is to do.
Okay, thank you for that. So Christina, I guess to bounce off that a little bit. I know that you're in a somewhat more specialized setting than, say, Dr. Bhatt is. Sort of asking the same question, in your healthcare model, what things are you doing that you think that are improving the health of the vulnerable populations you have? How is the data being used for good right now?
So I just a couple of years back, or maybe about 8 years or so, really focused on the medical home model, which is really similar to the previous model stated. And it really focused on being able to bring every aspect of health of the patient into the medical service. So if the patient had any social issues, being able to address those. If there was housing, being able to adequately make sure that the person who at the time of the visit is being able to get any type of their social issue addressed. But moreover, being able to focus on all the other health aspects of the patient, not just why the patient was there in the very beginning. And the reason being, with a lot of the American and Alaska Native population, it's the underlying issue that really bring the individual into the healthcare system, not so much the fact that they have a cold that day. And so being able to have healthcare providers who understand the population, I think is really critical for us. We were able to find, and unfortunately they are what's called locum, so they're temporary, but they have been in the Indian health system service for quite some time. And so they understand some of the really unique aspects of American Indian life, especially in the rural areas. So Dr. Bhatt stated with regards to appointment time, 15, 20 minutes. With most Indian healthcare services that are in, again, much smaller capacity, you're able to have longer visits to be able to just listen to the patient. A lot of times they really just want someone to talk to. So being able to have individuals who can really discern what the person is really telling them within their visit, but also being able, like I said, to utilize the culture of the people. I think too, a lot of times we really focus on the Western medicine for a lot of patients. And so you think of, again, health equity, how does that really fit in with American and Alaska Native patients? They still, for most of them, have their traditions, but often don't practice it. So being able to incorporate that into behavioral health, health and wellness activities, and then also reminding them and having their understanding that, you know, their way of life is health, their way of living is health. And so allowing them to define what health is for them, and again, utilizing that in their care. So being able to, and I know people use the term active listening, or being able to bring back to what the patient is saying to them, but really being able to focus in on how the patient views their health, how they view their ability to be able to improve that, and then work with them on those small steps. I think a lot of times when I first got here, it was situated, and it's only been a year and a half, but it was situated where we had the patient, that was it, but bringing their family on board and have caregivers, allowing their caregivers to understand what capacity they play in that. And as Dr. Bhatt said, when you have patients who aren't able to go home, especially a lot of American Indian populations who go into other healthcare services, such as your long-term care facilities or your rehabilitation facilities, often don't come out because they don't have the support that they would normally have with family and friends around them. So being able to build the capacity of their family and friends to understand the health needs that they're going to be once they are released back into the home, and again, building their capacity to use that when the patient is at home, but also being able to, in those long care facilities, have the support system of their families, our community health representatives to come by as well, to give them that familiar feel when they're away from home and not being able to be around their families. So again, utilizing the community's strength to provide adequate health care, and then in turn, as Dr. Bhatt said, to really focus in being able to bring that aspect even to the individual level as well as to the community level also.
Thank you so much for that. So Dr. Bhatt, I have another question for you. So I'm thinking more about what role do you think a partnership between industry, so whether we're talking about pharmaceutical companies or medical device developers, they have a large amount of data on populations as well. So what kind of information do you think can be shared between healthcare providers and industry to improve healthcare for vulnerable populations? Do you think there's a use for sharing information, and if not, why?
Thank you. I just want to echo Christina for her comments. I think Christina, you were spot on about how you're articulating some of those challenges, and I think in the Indian Health Service offers also us an important window into what it might look like if we were to organize care around the needs of where people live, work, learn, love, and play, and how that might improve the health outcomes, and how you can bring different, I think, elements of community together. And to your question about industry, industry can play an important role in sharing data with healthcare providers and healthcare systems, and with organizations that are engaged with vulnerable populations, whether it be the Indian Health Service, the VA, public-private sector, healthcare delivery organizations. One is looking at medication adherence. If we just ask the question, what is the differences in adherence across populations and place, you can get a sense of what might be some of the inequities there and the differences, and how you then might try to address that. I mean, is it because there's a pharmacy desert? Is it because that they don't have access or can't afford it? Is it because they don't have ways to get the medicine? Now that there's mail order and delivery, there's the opportunity to understand that. The other is around remote monitoring and diagnostics. We're I think being able to see that data and integrate it into the provider workflow, helps give a more fuller view of the patient and their engagement with important tools. But that data often sits sometimes just with industry, and sometimes doesn't get shared. But if it did, it could potentially be really useful as part of interventions, particularly around chronic disease. I think the other is related to clinical trial data, and there's likely use for clinical trial data in understanding populations patterns driving certain interventions. And we see testing, just in the COVID pandemic, where testing has failed to meet the needs of underserved populations or be available. We've seen vaccinations also have the same issue, unless you're an organization that's driving access, to those populations and communities, like the Indian Health Service or the VA or others. So I think there's a lot more that we could do together. Often, what we hear is that there's a conflict or at odds, a sort of profits over people rather than people over profits. And this notion, although, we've just seen, I think, what remarkable things can happen if we actually work together through this pandemic. I mean, treatments that could save lives and vaccinations in less than a year, which is absolutely unheard of. And particularly driven, the Moderna one by a Black woman scientist. And I think that, there's a lot of hope that I see from that.
Okay, I guess I'm going to sort of think about this hope that you said. So, COVID-19 will be around forever. But I think there's a lot to be learned from this period of time. And I think people have gone on and on about what we've learned about health equity, what we've learned about health disparities. I guess for both of you, I would like to know what you think would be most important about this period of time, what we've learned about sort of the state of healthcare in the United States, and what we could do moving forward with what we've learned to improve care for vulnerable populations. Like, what's the one thing that you think was most important about what we've gone through?
I think for us, the biggest piece was having an understanding that you can no longer sit on the sideline and wait for something to happen. I think COVID really brought to the forefront, especially with Indian Health Services, just the almost ineptitude of being able to provide services to those who are really in need in critical populations by just the use of telehealth alone. We had been screaming for telehealth for years and years and years. We were often told it was either not effective or just almost virtually impossible to implement in some areas. And COVID-19 really took that cloak of, how would I say, impossibility off, because when there was just no other way to do it, telehealth just was pushed at the forefront, and it became almost now a huge staple. And so with that, it drove many healthcare facilities to be able to kind of rally behind everyone and say, this is now the future of healthcare. This should be the ability to have not only healthcare be at the forefront, but being able to focus on infrastructures that have just been down critically for many communities. We know obviously you can't have telehealth without Wi-Fi. So then so many communities that did not have access to internet to be able to have telehealth were able to find money from the government as well as from other entities to build their infrastructure to provide Wi-Fi to those remote populations to be able to see where they are and provide healthcare in that capacity of telehealth. And so it was a gift and a curse in that it really, it no longer allowed people to be complacent. It really did not allow for communities and organizations, and primarily the big organizations, to just wait. Because then there was just no other way, like I said, to do healthcare. And so I think that was one of the biggest things that this COVID era really pushed to the brink, was the ability to really move forward in, I hate to say 22nd century, but basically in the future of technology where there was none before. Very, very few Indian health organizations were using telehealth, and now all of them were forced to use it. And so, but then too, we're not profit, however, but having your access, so your state Medicaid and other health insurances be on the forefront of saying, it will not only allow you to do it, but we're going to pay you to do it just like you would a regular office visit. And so that too really pushed the fight for just the mere essential things that we had been asking for quite some time to now come to light.
Thank you. How about you, Dr. Bhatt?
Yeah, so I would resonate with what Christina said and echo her comments. I think one, we've learned that we can innovate and adapt faster than we have on some of these issues that we've seen it. And I think that the other thing is, to the point of infrastructure, there's a lot of infrastructure gaps that were exposed and need to be addressed, from public health to data to communities. And I think that, from a data standpoint, if we're to look at what might be happening, I think social determinants or as an example of a spotlight on non-traditional data, and we're going to see more non-clinical data come into the mix to give sort of a 360 view and help try to make data better, to this point of, like, bad data that comes in is going to be bad data out and bad insights out. So I think we've got to get better at that as well. Mainstreaming artificial intelligence and machine learning, but in that issue, having a performance check on algorithms. We know that algorithms can be biased, and we need to make sure that we're thinking about the filter as we use algorithms and these new and advanced technologies, that it's not just take what the insight comes out and just use it, but actually put it through a critical thinking filter to see, if it actually translates and doesn't create more widened inequities or gaps. I think to the point about telemedicine, there's no going back, but the issue is going to be, broadband and access, and I think patients, providers, the industry are getting even more quickly adapted to telemedicine. And then, I think patient acuity, one of the things I see as a geriatrician is that we have patients in settings of care that might not be the right setting of care because they're potentially worse off physically, cognitively, and socially because of the pandemic. Yet, and so they may need a higher level of care, but yet because of the way that the structures are and the economics and how senior living and assisted living and nursing home kind of payment and reimbursement and long-term care payment and reimbursement works, people may stay in a care setting that is not actually the right care setting for them. I think people's health has deteriorated more than we expect because of isolation, because of the lack of interaction, because of not just having the same support. And sometimes you have to go downstream on data to find upstream opportunities. So I looked at, for example, where were there inequities in Illinois with diabetes, and when we looked at amputations secondary to diabetes, I would have guessed that Chicago would have been the hotspot, but it was actually a smaller county in Southern Illinois. And when you peel back the onion, it was because proportionally it had less space for physical activity. It had the worst primary care access of any county. It had the most liquor stores of any county. It had, those elements that accelerate chronic disease. And so, can we look at opportunities like that to say, well, how do we need to redesign a community and go upstream so that we can help keep people healthy? And I think, this is a pandemic that's touched everyone. And so I think that there's a lot of opportunity to help people tune in to be partners across sectors on getting to better health, and as a result, potential for opportunity and mobility for better lives.
Okay, thank you so much for that. I'm going to switch to Kirsten now to see if we have any audience questions.
Hello, and thank you. So if anyone has any questions from the audience, please just go ahead and put them in the chat. While you're doing that, I just want to thank Jay, Christina, Serena, Jennifer, and our life science company sponsors for helping to make these events possible. And ultimately, the organization will be putting out independent research funding to help really spur some solutions around exactly some of the issues raised. What would be the reforms to reimbursement? What would be the different types of metrics that could be standardized and rolled out to show progress in reducing health inequity? Barring any questions from the audience, I'll just maybe ask one that was with me, and then we'll wrap up, which is, Jay, you described shared savings. Is there a model where savings could go to the patient or the individual? And have either of you seen that be successful, whether it's reinvesting in the community, both to sort of demonstrate the reward of improving population health, but also to increase trust?
Yeah, there's definitely models that allow shared savings to go back into services for patients and families, or to use around social needs in the community, or to actually come together. Like in Chicago, we have the West Side Collaborative, which is a group of community-based organizations, health systems, public health, and private sector partners to address the life expectancy gap on the West Side. And some of the shared savings that accrue and our work with those organizations go back to them, to use in the ways that they want for their community and their organization. So there have been some models where it's gone back to individuals, and I think there are fewer, and I think we have to look at the data and see whether that actually is helpful and keeps people on a sustainable health trajectory.
Thank you. Christine.
I think within Indian Health Services, we have unfortunately a wide variety of services that are not available, especially services that are not available to community members within their own health system. And so the referral system is probably the most robust system in Indian Health Services. Using the dollars that are captured either through proper billing practices and so on, but to be able to bring those services back into the community. We know, for instance, we talk about just sheer access, being able to not have to go from 40 to sometimes over 100 miles to get to a facility that for podiatry, just simple podiatry. So being able to have that back into the facilities in the area, utilizing the funding for, there's some places who have medical transportation. So we have that as well, where we're able to pick individuals up and bring them here, but also being able to maintain the services that we send out. So your hepatic individuals who have to go far, and really being around, for lack of a better word, strangers. So again, being able to bring those services here, working with our partners in the area to be able to bring the specialists into the facility again, and not having to send patients out, have been a really successful model, so that in turn, again, this is their home. This is what they trust. And so they're more likely to be more compliant with their appointments if they're coming to a place that they're familiar with, versus having to send them away to a new facility, having to get to know the new environment there. But also here you have the guided, you have the ability to guide them through the healthcare system. And so utilizing funding to increase that capacity within the community, I think had been, is seen in several places. We're still working on that here, but it has been a huge increase in positive health outcomes in some communities that have been able to utilize the generated revenue from the individuals that they've been able to capture in their facilities.
Wonderful. And then a question from the audience. How do you capture data from individuals who either have low health literacy or maybe even reading disabilities, where the typical models of communication might be a challenge? You've seen good ways of doing this.
Yeah, I think this is important. I think health literacy is a critical social determinant of health. It's a social need. And one of the ways that we've seen is through community health workers, and through also partners that help people with disabilities, that work with them to capture that data. So for example, with our health risk assessments, we have community health workers and care managers, that help people that may not have the same literacy to do it on their own, or may have other challenges in order to sharing that information. I also think it brings up an important question about what does digital literacy look like as we continue to accelerate that effort. And it might be, something that the industry can partner with providers on, and healthcare organizations. I think that industry has done really critical work in underserved communities. I know some of them have worked to support low dose lung CT scanning in underserved communities, and it was actually really remarkable how you found earlier stage cancers, because traditionally 75% of those people end up presenting in stage 3 or 4. And I think from digital literacy to new models of care. I know that in my previous role, American Hospital Association, we worked with industry around a collaborative care model. So I think that there's a lot of opportunities, but this issue of health literacy is important, because I think sometimes there's assumptions being made about populations, what they can and can do, and I think we need to look at them deeper. And then there's this question about youth, Kirsten, if you wanted to talk about.
Excellent. I'll see if Christina has any response on the health literacy, and then maybe we'll have the youth question as our last one.
Thank you. Dr. Bhatt actually really touched on the utilization of community health representatives. We have community health workers, we have the same. I think we also, when we go through the process of actually developing the questions for the community health risk assessment, our community health assessment, our community health improvement, any of those type of like public health aspects, we really focus on vetting it through the community. So actually write it in the language that they understand. And I think it's a critical piece in that, because while it may take a lot longer for the process and for information to be approved, it really hits home with making sure you're getting the information that you really need from the community in which you serve. And so we found that vetting the information with community members prior to utilizing any of the assessments that we have has been very successful, because in turn they understand the information that we're trying to gather, and also they tend to be more, like I said, they tend to have more buy-in, because they know that they had a hand in developing the questions and formulating the responses. So I think using again the population that you serve is really critical when you're trying to gather information from them. And that's it. I think Dr. Bhatt was going to go to the youth question.
To give you a quick format for your final answer, what would be the one or two pieces of information you'd want to collect from a young person in a health visit to set them up for better health in the future?
Yeah, so I think that early childhood development is such a critical part of the health trajectory, and I think we've got to invest more there. And one is I'd want to know about their kind of support environment and their data related to mental health, and what they might have experienced or have impacted them and where they are today. And then I'd want to know about their education and where their level of kind of education and literacy is at. And I think that can give insight into what kinds of support they might need moving forward, to the point of, I think I worry about the pandemic and where our children are at, which they're so far behind as a result. What are we going to do, to accelerate and support those that might need more? That's equity. You got to support those with more resources that might need more resources. And I think that's what we got to always have, that lens in mind.
I'm in total agreement with Dr. Bhatt. I think too, the other aspect is focusing on their home life. So being able to have them at best articulate how they're able to stay healthy at home. I think this pandemic really, as was stated earlier, shed light on numerous inequities, but even more so the living spaces of our youth, and how that directly impacts their ability to be able to function in society. And so having them to be able to understand how, if they're getting enough sleep, if they're getting enough to eat, if they're getting just to eat in general, how that really impacts them moving forward, to be able to be, to grow up as self-sustaining adults.
Thank you both, and thanks for a great discussion. Appreciate